Okay, so we are recording the session. So if you are watching this back later, hello, welcome. And for those that have joined us, thank you for giving up time on your lunch break. And I'd like to thank Dr. Judith Ibison and Dr. Bassel Wattar for giving up time in your busy days and your lunch break to come and have this important discussion around PCOS and management in primary and secondary care. So we're very grateful for your time and for your expertise that you're going to share with us today. I'll hand over to you first, Judith, to introduce yourself, and then Bassel, and then we'll dive straight into the webinar.
Hi, I'm Judith Ibison. I'm a GP in Brixton, and I also very involved in education at St George's, University of London. And it was here I really got interested with PCOS with a previous contributor to Verity, Helen Mason, who's a physiologist. So I've been involved with the charity since then.
Hello, thank you for having me today. So I'm Bassel Wattar. I'm an associate professor of reproductive medicine and consultant gynecologist at Epsom St Helier. I run a dedicated endocrine clinic for PCOS at St Helier's Hospital and lead a research group called EV at UCL focused on PCOS health. And most importantly, long-time advocate and supporter for Verity, and really pleased to be joining you today on this webinar.
Thank you both very much, and hopefully if you could just give me a yay or nay that you can see the screen okay?
Yes.
Yeah.
Perfect. So how we're going to do this for everyone that's attending, there is a Q&A chat box on your screen, so please use that to ask your questions. I will go through and pose those questions to Judith and to Bassel as we go through these slides and the talking points. So let me dive straight through. And a lot of the questions, and many of you have sent questions in advance when you registered, and I'm going to apologise in advance. We've probably had about 50 questions, plus the ones that we will get today. So we're not going to be able to get to them all, but hopefully your question or a similar one will be answered during this. So these are some of the common questions that come up around how do patients utilise their GP for PCOS management? When should they be seeing a specialist? And Judith, if I pass over to you first around some of these common questions and working with your GP.
Yeah, I mean, I think the first thing I would always say is to find a GP. I know it's extremely difficult to access a GP at the moment, but in some ways the new triage systems that are operating may help you find somebody who knows something about PCOS at your practice. So find a doctor, perhaps, and I hope I'm not being ageist in this, but likely to be a more recently qualified doctor or somebody who's got an interest in women's health, who knows something about PCOS. Prepare your questions before you go, and then you may find that having a kind of email exchange or a text exchange or a telephone conversation is as good as having a face-to-face conversation, but all practices should be offering face-to-face consultations now at your request. We're certainly doing that at our practice as well. So I think that would be my advice, is be assertive, be prepared, and persist until you find somebody who you feel comfortable talking to about your symptoms.
Right, thank you. So what is PCOS?
So I'm sure we're talking to an expert patient forum here who are very familiar with many of these symptoms. Obviously, it's a condition that can vary in presentation between women and vary to some extent between women of different heritage in terms of the predominance of different features. The cause is not well understood, but the manifestations that women may experience are irregularity or absence of periods. That can be one symptom that occurs. And then symptoms also of having higher than average androgen levels, such as acne or hair loss on the top of the head, or excess hair in other parts of the body as well. The symptoms of PCOS tend to get worse if people are overweight, and the trigger side of that is that losing weight tends to reduce symptoms of PCOS as well. It does affect people throughout the life cycle. So in younger women, gynecological issues, skin and hair issues may be predominant, but it also has an impact on pregnancy, and we'll talk a bit more about that later. And most importantly, it also has a consequence for your hormones that regulate things like your risk of heart disease and also diabetes as well. So it's important to consider those as people move from being younger women into middle-aged and older age, to think about monitoring for those complications as well. I don't know if Bassel, you would want to say anything else.
No, I think you gave a fantastic summary, and I completely agree. I guess the key is to understand that it's a lifelong condition. And while I think with early interventions, someone can pretty much manage all of the symptoms of PCOS and have very minimal impact, there is no cure that we know of. And I think, like we started the slide, knowledge is power. So encourage everyone to know more about this and use, obviously, the fantastic resources from Verity and other charities to understand their health, and continue to engage with health professionals as they progress in life, because their health needs will change and the manifestations of PCOS and impact will change. And it's important to, stay in control and understand how things will evolve with your body.
Great, thank you. And we've had a question come in the chat box, which we will address. Is fatigue a symptom of PCOS?
Is fatigue? Sorry, yeah. So, fatigue has got a million causes. I'm not sure. I think that there are a million causes related to PCOS that would cause fatigue. So, if somebody became anemic because of heavy periods, for example, or if somebody became diabetic and had high sugar levels, both of those, would be associated with fatigue. I'm not aware that fatigue in the absence of any other sequelae of PCOS would cause fatigue, but Bassel might be better at answering that question. I think my final sentence would be that please see your doctor if you're feeling fatigue, so that they can look for endocrine and other causes of it and anything related to PCOS.
Yeah, no, I agree. I think fatigue is unfortunately a non-specific symptom that can manifest from several health conditions. So if you have diabetes and cardiovascular disease and so on, any other complications of PCOS, you will come up, you might manifest with fatigue. On its face value, we know that PCOS is associated with higher oxidative stress, and there is higher inflammatory markers happening in the body with PCOS that might trigger these symptoms of fatigue. But unfortunately, the research is a bit lacking in terms of, we don't have a causality link that PCOS will cause fatigue, but more probably the consequences of PCOS might be contributing to fatigue.
Great, thank you. Just a reminder, if you do have questions as we go through, just pop them into the Q&A box at the bottom, and we'll get to those as we go through. So in terms of, if someone suspects they have PCOS, what should they be doing? Who do they go to first?
So, of course, I would always say go to your GP first. There are many conditions which can cause the symptoms of PCOS, and, the symptoms appear in different groups in different individual women. So the GP is a good bet to go to first. And I would say that probably, and be good to get Bassel's view on this, I would say about 95% of women with PCOS clearly have it, and a diagnosis can be made on the basis of a history examination, basic blood tests, and an ultrasound scan, if usually would be required as well. And all of that can be arranged in primary care, and fairly confident diagnoses can be made. Again, as you probably all know, the key features are having irregular periods or no periods, and again, those symptoms of having high androgen levels being expressed, such as acne or excess hair. And then if you do have an ultrasound, finding lots of small follicles within the ovary on ultrasound alone. But you need 2 out of those 3 sets of symptoms in order to have a diagnosis. As you probably know, about 20% of women will have polycystic ovaries but not have polycystic ovary syndrome, so they won't have the other features of the condition. I think it's about 10 to 12% that might actually have the condition, but Bassel can correct me if I'm wrong. So you need 2 out of 3 of those sets of symptoms. Now, there are some very rare conditions which will be suggested through the clinical features of women who present. So, again, that history taking, that examination is really important, that will indicate that it might be something that is not PCOS. Again, your GP can do some basic investigations in that situation, but if they're not confident, then that's where we would hand over the baton to our colleagues in secondary care who would take over the diagnostic process. And usually it would be people like Bassel, who are gynecologists with an interest in PCOS, or endocrinologists with an interest in reproduction, to whom we would be referring. Anything you'd like to add, Bassel?
Spot on. I think you mentioned, so the name of that diagnostic criteria is Rotterdam. A lot of patients will hear that name but not make relation that it's actually used to diagnose PCOS, and it's a collection of symptoms. And I completely agree. The first port of call should be the GP, because they're best placed to sort of diagnose and initiate early treatments rapidly. Some minority will need to come to a secondary care, and we're hoping and trying that there will be more dedicated PCOS services that are multidisciplinary between gynae, endocrine, GP, and dermatology, and so on, so that there will be faster access to diagnosis and treatment. I think this is hopefully evolving in the NHS. And in the small minority, the diagnosis might not be very straightforward, and it requires a little bit more investigations and blood tests and other investigations. But unfortunately, a lot of women experience delayed in diagnosis, and that is usually due to hesitancy or lack of clarity in the symptoms appearing. But that can be resolved in secondary care.
Great, Judith. I can see that you've tagged one of the questions in the Q&A box to answer. So that was around hypothyroidism and PCOS. And someone has said that they have both, and they were recommended going on the pill by the GP. But would you recommend that they actually see a specialist? What are their options?
So, I think if they've got a clear diagnosis of PCOS, going on the pill, as we'll talk about in a minute, is dependent on the context of the individual woman. So whether she's seeking contraception or trying to get pregnant, first of all, but also the nature of what her bleeding is. I think the hypothyroidism can be dealt with as an entirely separate issue that can routinely be dealt with by general practitioners. They're very experienced in that. It just requires taking some replacement thyroxine to normalize the body's underproduction of thyroxine, and monitoring that with 4 to 6 monthly blood tests, and pretty much all GPs will be capable of that. So I don't think there's a link between the two. I'm not aware of a link between the two, so I'd treat them separately, and the context of the pill for PCOS will perhaps come on to in a minute.
Right, thank you.
I was going to type, so sorry about that, Rachel. I thought
okay.
I might be able to type answers, but we can't
that's
do that.
Okay. I'm sure it's beneficial for those that are watching this back later. I'm sure that's not the only person that has that question. One of the common things that we see time and time again is that someone has been diagnosed with PCOS. They've been told, and this is also a question in the box, that they have the follicles present, but then they might later on in their life get re-scanned and told that their PCOS is gone because the cysts, the follicles are not gone. Can we address that question, please?
So I saw that as whether it worsens with age. So the answer is it really depends on each person's situation, because if someone is gaining more weight as they advance, their PCOS might be manifesting with higher, for example, risk of diabetes and cardiovascular disease. But if there are no other changes, usually the symptoms of PCOS do improve a little bit towards age and towards the menopause. That doesn't mean they completely disappear. So it varies, and as we previously mentioned, the appearance on ultrasound is only one diagnostic feature. And if you already have a diagnosis of PCOS and then you don't find the appearance on ultrasound, it does not mean that PCOS has disappeared. It just means that the symptoms are changing and the pathophysiology is slightly changing and evolving. And your doctor should understand that and work with you to address the remainder of the symptoms.
Great, thank you. And another question that we see time and time again is around pain and PCOS. Is pain a symptom of PCOS?
So in my experience, I mean, there are women who get very heavy periods. So, you know, one might get increased dysmenorrhea or period pains. Again, really be proactive about that. There is no need for women to have period pains in this century. You know, like acne, like other symptoms, don't think we should have to tolerate them at all. So please be proactive about going to see your GP for either analgesia or for menstrual, you know, regulation in some way with the pill, etc., or indeed investigation to see what the cause of the pain might be. Bassel, any other comments about pain?
No, I agree fully. I mean, there's sometimes cases, for example, where someone might have endometriosis, adenomyosis with the PCOS that might be flaring up the pain. That doesn't mean it's always the case. A proper diagnostic is needed commonly with an ultrasound scan or a laparoscopy. If we're specifically talking about period pain, there might be generalized body pain or fatigue. Again, this could be related to other symptoms and could be aggravated with the inflammatory status of the PCOS, but it doesn't mean that the PCOS is causing that directly. But as I say, it might be contributing to it. So it's important to explore the pain symptom within the wider context of what could be potentially causing that.
I mean, I'm not the doctor and the medical expert on the call, but I would just add through, you know, my experience within the charity and the discussions that we see is a lot of time people are associating the pain that they're experiencing with an ovarian cyst, for example, and then associating that as PCOS or missing a diagnosis of something like endometriosis or adenomyosis. So I think that's really an important distinction to make, is that PCOS is not a pain. Pain is not associated with PCOS, although you might have pain because of a painful period, but any other causes of pain should be investigated. And then I guess, Judith, the first point of call for that would be a GP like yourself. Right. Another question in the chat, and we'll get on to, we've got some great slides to come, but lots of great questions as well. So one of those is, a lot of people online claim that they have reversed or cured their PCOS through diet and exercise. Is this ever really possible?
So I would say yes. You know, we appreciate totally how difficult and challenging it is to lose weight. In our obesogenic environment, but also especially if you have PCOS, it's also very hard, you know, certainly for a lot of my patients, to safely exercise or to afford exercise. So there are lots of barriers to doing that. But certainly I have had patients who have managed to lose weight and exercise, and their PCOS symptoms have improved. And, for example, periods have come back. Bassel, would you like to?
I agree. As we discussed, is that I think with early intervention and proper weight management, as well as other things, I don't want to focus too much on the weight. You can, as we discussed, pretty much manage all the symptoms of PCOS that you barely have any consequences of it. Now, it doesn't mean that PCOS is gone and is not going to come back if you regain the weight. It's a condition, as we discussed, for life, but you're managing the consequences and the symptoms of it. And significant weight loss has been attributed with quite significant reversal of the symptoms of PCOS.
I think that's a distinction that we should be, I guess, clear on, is reversal of the symptoms is in the symptoms going away, but the PCOS you have for your lifetime, and there is no cure or reversal of the actual condition, but that symptoms may be managed. Or
see the problem is that we're diagnosing PCOS based on the symptoms. So if the symptoms are not here, we don't have a blood test that tells us this is PCOS.
We have the AMH blood test. So even AMH is telling you that there are so many follicles on the ovary. It's not telling you that there is PCOS or not. So all the diagnostic features are based on symptoms, and if we cure the symptoms, then one would wonder, how can we
for sure tell that PCOS is gone. And that's a dilemma in the research that we have. And that's why I'm saying, with these intervention, you're eliminating these symptoms. Now, whether if you, for example, regain weight, your PCOS will appear, that is something to explore further.
So do we know through research then if someone has, lost weight or they manage insulin even if they don't need to lose weight and their symptoms have are not present anymore, or do they still have the same risk factors in as other PCOS patients, like sleep apnea, like fatty liver, like cardiovascular disease, miscarriage?
We have very limited sort of longitudinal long-term cohort studies that are following women through that scope that you suggested, but the evidence so far is suggesting it depends on how long you had exposure to the abnormal symptoms. So if you've had obesity and your insulin resistance was high for a very long time, it doesn't mean that and then you lose the weight, you have reduced the risk of becoming diabetic later in life. You have not completely eliminated it, and it depends on how long you had that exposure. I don't know, Judith, if you have any other comments to add.
No, I think that's a really good answer, really. I think, it relates back to Bassel's point about us helping younger women recognise they do have PCOS and addressing this from an early age, because it's hard to suddenly start addressing it in middle age, for example. Not impossible at all, but much better to kind of start when people are younger if possible. And I think the other thing I'd say, like diabetes really, so obviously we've got lots of patients with diabetes who don't have PCOS, and again for people who do manage to lose weight, they do lose the diabetes. So type 2 diabetes will regress very definitely. And I think ongoing risk will depend, as Bassel said, how long they lived through the risk of that diabetes being present, and how long when they haven't had that risk from diabetes being present. And that will depend on the age at which the intervention happened.
To tie into the question and discussion around early intervention, so helping someone that maybe has been diagnosed at risk of PCOS as an adolescent, one of the questions here is how likely are we to pass it on to our daughters, and how can, I guess, we as parents help our daughters avoid developing PCOS, knowing that they carry an increased likelihood of that? And as a mum of 2 daughters, I'm listening intently to the answer.
So I don't know the heritability, actually. I bet Bassel does, so we can pass it on to him in a second. But as you'll see from the previous slide, it's really important not to diagnose this too early. And I've seen, young people at the age of 17 previously given diagnoses inappropriately because they had irregular periods or infrequent periods around when their periods started. So I think the first thing is, as mothers, friends and grandmothers or whatever, is that, we need to be aware that people need to reach reproductive maturity before you think about diagnosing it. That's one thing. But I think as friends, mothers, grandmothers, we can do our job in terms of alerting people to what the symptoms are, so that that our friends and relatives know what the symptoms are and can do something about it and be encouraged to do something about it if they do appear. But heritability, Bassel.
Yeah, I love doing these talks with Judith because she often always give the wisdom piece first and give me which summarizes everything brilliantly. So I completely agree. Look, I can talk about this for an hour, but basically, in very simple terms, for us to say that a condition is heritable means that a father or a mother will pass it to their offspring, irrespective of what environmental factors that come in, and which we have not been proven in PCOS. We know that there's 2 factors. There is some sort of gene disorder, and then there is the epigenetic or the environmental factors. It seems that it runs in family, but there is no robust gene sort of passing on from generation to the other. But there is also this hypothesis that exposure in the womb for a baby to high levels of androgens, which is the testosterone in this case, is more associated with the child developing PCOS later in life. So this is exactly comes back to the idea we spoke about, is that you're planning for pregnancy. It's very important that you get these lifestyle interventions and other help to manage your PCOS and control all the complications of it, so that you create a healthier environment for the baby to reduce that risk. Now, is this robust, meaning 1 + 1 = 2? No, the evidence is still emerging, and our technology in detecting sort of the epigenetics of this is improving with time. We're seeing more and more of these studies, but for now, we cannot say it is completely heritable, but it can pass from one generation to the other.
We've got a couple of questions here around working with your GP. So I'm going to combine them both into one question. So one is, where is the best place to find information about PCOS if your GP is inaccessible? The other question is, I was told by my GP that it's not necessary for me to get an ultrasound as my clinical symptoms are enough to diagnose me. However, I'm worried that I have cysts/follicles. Any advice on what the best thing to do is?
So your GP is right that there's no need to do an ultrasound in terms of making a diagnosis. So the diagnosis can be made on the basis of symptoms. However, I would tend to do an ultrasound as part of the diagnostic workup and looking for other tests as well. So I don't know, Bassel, perhaps you could adjudicate on which of us is right, but given people normally have other sorts of symptoms as well, I would tend to do a confirmatory ultrasound as well.
No, I agree with you. I think the logic is sound in that you can establish the diagnosis without the need for an ultrasound. And this is specifically, say, if you're in the community and you don't have access to an ultrasound machine. That doesn't mean that the ultrasound has no value. For example, I don't know, the viewer's age, but for example, if you are in your 40s, I'd be interested to know if you have thickening of the lining of the womb, what we call endometrial hyperplasia, which we can already diagnose on ultrasound. While we're investigating PCOS. An ultrasound can rule out cysts, which are not part of PCOS. So PCOS says polycystic, but actually they're follicles, they're not cysts. They are completely different categories. And then there are other elements that we can diagnose at time of ultrasound, for example, endometriosis. So the ultrasound does have an added diagnostic value to the symptomology of PCOS, but it's not mandatory to achieve a diagnosis. You mentioned about resources. I think the NHS has somewhat okay resources. Verity, I always guide all my patients to read Verity resources. Jane Heels from Australia have very reliable resources as well. And I think PCOS challenge, but they're more American, so they're not very applicable to the UK.
And we've got some resources at the end of the slide set as well, so we can show you the resources we've put up there.
I'll just add that there's a fantastic app which is called PCOS. Ask PCOS, sorry. It's a free app on Android and Apple devices, and it's from the International PCOS Guidelines, which is an international collaborative effort of evidence-based information. So that's a fantastic resource for healthcare professionals, but also for patients. And the Ask PCOS app is for patients. So that would be a resource I would recommend. And I think, Bassel, you touched on the important clarification there between cysts versus follicles. And I would say for the person asking the question, they're potentially, the way that the question was phrased, they might be potentially worried about their follicles growing and bursting like a cyst would, because that's a common theme we get. So just to clarify that your follicles for your PCOS diagnosis are not the same as ovarian cysts. Great. And we've got a few questions coming in around the contraceptive pill. So I'll combine those again, and we've got, I think, the slide up around that now. So one is, which pill is better in PCOS? Is there an advantage of an anti-androgen like drospirenone? And I'm not sure if I've pronounced that correctly.
You have.
Good, thank you. And what is your opinion on treatment with pharmaceuticals? That's not specifically asking about contraceptive, but we might be able to touch on that as well. And can you please cover treatment, especially choice of pill? Is there one better than the other? And is the pill used especially in younger patients associated with an increased risk of breast cancer?
Okay, so I'll make a start, and perhaps Bassel, you can do the difficult bits again. So I think a choice of pill depends on the context of you and your individual situation. So if your situation is that you're having no periods, for example, and the pill's being used as endometrial protection because you also want contraception as well, and you don't have acne and you don't have hirsutism, then it doesn't matter which pill you use. You could use a progesterone-only pill, or you could use a combined estrogen and progesterone, but one that doesn't have to be particularly kind to the skin. In terms of acne, so we used to give pills which were very friendly to the skin, with progesterones which were friendly to the skin. But as far as I'm aware, the guideline has changed, and in terms of treating acne from the dermatologists, they don't recommend any particular sort of progesterone. I have to say, in my experience, they do tend to be better for acne. The ones which are less androgenic in terms of the progesterones they contain, but you have to also accept that they tend to have a slightly higher thrombotic risk with those pills as well. So there's never a free lunch with any medication, unfortunately. So there are tablets like Marvelon or Yasmin, which are better for you. But compared with the normal contraceptive pill, the risk of venous thrombosis or DVT is slightly higher. And we are talking slight. So we're talking about an increased risk from 25 per 100,000 women, from 15 per 100,000 women to 25. So it's about 10 per 100,000 women per year of use. So it is small, but it is there. But in my clinical experience, they tend to be a bit better for treating the excess androgen type symptoms. In terms of the breast cancer risk, there is indeed an increased risk of breast cancer with taking estrogen or progesterone. In young women, because the baseline risk of breast cancer is very low, it's very much related to age breast cancer, though not exclusively in mid to older women. The absolute risk is very small, and I think it's something like, for sort of 20 to 30-year-olds, something like an excess risk of 250 per 100,000 women for 5 years use, something like that. So 250 sounds a big figure, but if you think about Wembley Stadium full of people for a year taking the pill, it's 250 people out of that size of crowd. The risk of breast cancer declines with time since you use the pill. So if you stop using it, your risk will go back to normal eventually. I think I've run out of remembering what the questions are. Bassel, what have I not covered?
There you go, you covered everything brilliantly. And my only comments is, look, there's some myth that you have PCOS, you have to go on the pill, and I completely disagree with that. We are blessed in this country that we have access to 60 plus types of contraceptive pills. And there is no one size fits all. There is no one pill that is good for every woman with PCOS. It's all about individualizing treatment. So when I'm meeting with someone, if they are PCOS and they have a BMI above 35, I can't give them the combined pill. They need to go on something alternative. If they have migraine, I might need to change the type of progesterone in their pill. If they have a previous risk of VTE for a clot in the leg, for example, I have to choose something accordingly. So it's not one size fits all. We do know that the pill seems to improve some of the symptoms of PCOS. It does not cure everything. And the key grounding principle is that everyone with PCOS should have at least 4 periods a year. It's very, very important to reduce the risk of uterine cancer. That needs to be then translated by understanding each person individual characteristics and trying to choose out of these 60 options which is best for you. Now, you heard Judith very eloquently saying all these numbers. Most gynecologists cannot regurgitate these numbers, so GPs deal with contraception way more frequently than gynecologists, unless they are specialist gynecologists doing reproductive medicine. Then they get more exposure to the more advanced. The good news, there are new pills coming on the market. So traditionally we'd used to give Yasmin, for example. Now there's something called Revelis that have a wider safety feature. I'm not paid by any pharma company, so disclosure, I'm not doing any marketing. And there are new pills called, for example, Rieco, that is blocking all the periods with some HRT element to it. So there is new things coming and moving that we can leverage to better manage PCOS, which is really promising and exciting that we might be able to offer an option to someone, for example, who had a BMI in a previous clot and might not be suitable in the past. There are different types of coils, so Mirena is no longer the only coil on the market. There are other alternatives as well. So things are moving, and the key thing that, to say is really work with a doctor that understands your individual circumstance. And look, it's a trial and error. I tell my patients, I don't know how your body will respond to this pill. You might take it, not like it. Don't worry. We'll find an alternative. We'll work together to find something that really suits you individually.
We have, and you touched on it briefly, Bassel, but one of the questions was around they hadn't heard anything about inducing a period until our talk today, which I think is, if we can get that message out, that's an amazing result to have. So why is it important for a woman with PCOS to have 4 periods a year, and what should they do?
Judith, why don't you start from a GP perspective?
Okay, so it's important. So the thing that we're trying to avoid by making sure that women have 4 periods a year is the development of something of a thickening of the lining of the womb called endometrial hyperplasia. So when you're not having periods, you tend to have quite a lot of estrogen around in your body because you usually haven't ovulated, and in a way your body's trying to get your ovaries to ovulate, and so there's a lot of estrogen around. This leads to thickening and lining and stimulates the womb lining cells to change somewhat, and they can develop into this thing called endometrial hyperplasia. Now that risk is totally reduced, I think, if you have at least 4 periods a year. So for women who are not having any periods, where in a way they're living in a kind of pre-ovulatory phase, and that's going on for 6 months or 9 months or a year, there's an increased risk of that lining of the womb thickening. And if you create the endocrine environment of having ovulated by giving some progesterone, such as medroxyprogesterone, for example, 4 times a year, then you will have a normal period. The lining of the womb will flush out. You'll get new cells developing with the next period that's onset, and again they'll be flushed out 4 months later, and so you might vastly reduce the risk of the endometrial hyperplasia.
We have someone that has commented that they got endometrial hyperplasia and was given Provera for almost a year to treat this due to constant bleeding. They're concerned as they wonder if that was caused by the PCOS, and what should they do fertility-wise to try and get a normal period to return?
I think it's difficult to know without knowing the individual context, perhaps, and the age and relationship to menopause, etc. What would you say, Bassel?
I agree. I think we can't give individual advice, but from a fertility concept, which is important that this lovely lady is pointing out, is that this having hyperplasia can really complicate seeking fertility, because as a fertility specialist, I want to know that someone is safe and not at risk of endometrial cancer before, say, they're going through normal pregnancy or IVF. So this will need sort of very close monitoring with a trained gynecologist in this area to try to cure the hyperplasia or reverse it, and then very quickly time the pregnancy, and then after the pregnancy also continue to do several interventions. This is not just Provera, this is also weight loss, and as well as other alternative. Basically, hyperplasia is a end product of several factors, and we need to try to reverse these factors to make it regress to normal.
I'm going to kind of condense a couple of questions in one, which are of a similar theme to what we've been talking about, and then we'll move on to another topic because we still have weight loss, fertility, acne, hair loss, mood and mental health to cover in the next 20 minutes. PCOS is just
Very doable
in terms of topic variety. To summarize a couple of these questions, what are your thoughts on micronized progesterone as part of a treatment plan for a patient with PCOS, not as a contraceptive? What is deemed to be an infrequent period? Is it anything less than 1 a month? And also, can we have some advice around how to actually approach the GP with regards to a lack of period? This particular person has said they probably have only 2 a year, but the GP is not giving any assistance apart from advice to lose weight. So what can we do?
Okay, that's really a heart sink scenario, the last one. So I think if that is truly the case, that somebody's having fewer than 4 periods a year, so that's what we're aiming for, is 4 periods a year, and the GP is not listening, then I think the patient needs to represent themselves to a different GP or change practice, because, obviously, if they're trying to get pregnant, then a referral can be done to a fertility specialist to induce ovulation, etc., if they're only having 2 periods a year. And if they're not trying to get pregnant, then it's not normal and they need to be having 4 periods a year. So definitely explain to the GP why you're doing that, make a complaint about the GP if they truly have said that, and find somebody who does know something about PCOS. I know it's difficult to register, but you usually will be able to register elsewhere in a locality.
We're going to share a resource, top tips for working with GP and resources that you can share. So that will be across our social channels, probably by tomorrow. So let me just see.
Was there something we missed there, Rachel? Sorry, I was so shocked by that.
What counts as an infrequent period? And I think you covered that. It's anything less than
a
year. And then the tips to work with the GP, which you covered.
There was micronized progesterone, Bassel.
Yes, sorry,
so I'm not familiar with that in relation to PCOS, only in relation to the progesterone component of HRT, but Bassel might be more.
I mean, look, as Judith said, unfortunately, we don't have many contraceptive pills that are offering micronized progesterone. It can be used to, instead of, say, of Prevera or northisterone, to induce a period. Most commonly, it's not used as so just because of cost. It's more expensive, and that's why it's not commonly used in the NHS for that indication. But it's a very valid option. And long term, we know that micronized progesterone it's more natural progesterone, so it has a higher safety margin compared to other types of progesterone, and less side effect profile like breast tenderness or water retention symptoms. So it's a very viable option. I think it's becoming more and more available. So more and more gynecologists are using it nowadays.
Right, we'll move on from the pill just because we have so much to cover, but we will also circulate the slides, which have some links and some resources here to talk about that. And around weight, so Bassel, sorry, just if I can point you to the Q&A box, there's a question around the name of the new pill. Maybe you can type that answer in, because I will, I'm sure, misspell it. So questions around, I guess, if you're someone that has PCOS but weight is not one of your symptoms or issues, what can you do? I think we hear quite frequently that someone that is not overweight with PCOS, they often feel neglected in the advice, because the first line of advice is commonly go away and lose weight and your symptoms will improve or go away. So what does someone that is slim with PCOS do?
Well, look, it's about a systematic approach to PCOS, and the patients who are slim and they don't have they have PCOS, they're commonly the ones who have the higher testosterone levels, and they often have the more sort of rough end of the spectrum, because their pregnancy is at higher risk, their fertility is a bit more profound, they respond less to fertility treatments, and they're at higher risk of developing diabetes later on, even though they're not higher weight. So it's important to, again, engage with your GP or PCOS specialist to go through all the symptoms of PCOS and try to address each symptom at a time with the appropriate intervention. So if they have For example, if we've done their HbA1c and they've been found to be pre-diabetic, they need to go on metformin. If they're not having periods, they need to go on the pill or induce 4 periods a year. If they're having very bad hirsutism, they need to have a treatment for their hirsutism. So it goes back to adopting that systematic, comprehensive, holistic approach to PCOS, and not just focus on the weight, as you alluded.
I'm conscious that we have quite a lot of questions in the chat, and also that have been sent separately that we just will not have time, unfortunately, to get to, but hopefully we can entice both Judith and Bassel back to do another one of these and answer some of these questions.
Pleasure.
If we quickly, we've got about 15 minutes left, if we can quickly, if it's possible to talk about quickly weight and PCOS. Some of the questions are around what diet is the best to use. Others are around GLP-1 receptors, and I'll allow you to explain what those are. And I'll pass over to you. And I'm just going to pop a poll in the chat if it allows me to do so, just to capture some of your own experiences. So do see if that pops up for you. But Bassel and Judith, over to you. What options are there for weight loss, and what works? What's best?
Okay, perhaps I can just start this off by saying, it's a really, really common issue for women generally, but obviously also, particularly women with PCOS. Treating this holistically, it is tough. You've got to be in a good place to approach losing weight. So I think my top tip for women when they come and see me is just to think about how they can give them some space for their own health, because they're obviously often busy looking after a million other people and doing 2 jobs at the same time, and so just don't have the psychological space to think about changing their diet or finding some more exercise, etc., in their busy lives. So prioritizing yourself, and if you find it difficult to do that, getting some support with talking therapies, etc., just to look at what the pressures and barriers are on you to thinking about being able to prioritize yourself and approaching losing weight. As far as I'm aware, there's no particular diet which is particularly helpful in women with PCOS. Bassel is putting together a big trial to look at that. Hopefully that will get funded to investigate that. But really it's about empowering yourself with knowledge about food and weight gain and diet, and looking at what you eat, using the resources that there are available. And I think it's particularly an area where there's a lot of snake oil on the internet about what might help or what might not help, but seek advice from dietitians and specialist weight services, which are available everywhere across the country. There are various tiers of this depending on what the weight issue is. Our practice has got access to health and lifestyle coaches who will help you in terms of motivation, setting goals, and whether that's exercise or weight. So look out for those sorts of services locally, and talk to your GP as well. Although semaglutide is licensed, it's hardly available for people with diabetes at the moment. So we've got diabetics who can't access it, and certainly it's not available through the NHS for weight loss at the moment. I suspect that commercial pressures will mean it will be in future. Bassel will know more about this. I'm not sure about long-term data with semaglutide yet. It's probably been around for about 10 years now in terms of long-term benefits and hazards. But what does seem to be the case is that once you stop using it, appetite returns and people are at risk of putting weight on again. So it's not a cure. It's a kind of suppressant, appetite suppressant. That seems to be how it's working. Bassel, anything you'd like to add?
As always, fantastic summary. I completely agree. And I notice Rachel has put the poll, and would appreciate to hear the views of our audience, because it's very important. As we mentioned, we're very excited that finally, after a lot of scream and shout from us, the government is willing to fund a big study on what is the best sort of lifestyle intervention for weight loss in women with PCOS. So we want to hear the views of women, and we appreciate it. We do not know the honest answer. I think we're guilty in the NHS. We often patronize the patient. We tell them just go lose weight and stop eating. And that is so ill-informed and so unhelpful to the patient, because I think any lifestyle intervention should understand and focus on the pathophysiology of PCOS, because we do know that it's harder for women with PCOS to lose weight. We do know that they have higher insulin resistance. We do know that they do not metabolize sugar very well. So it's unfair to just say, oh, go lose weight. It's not an easy journey. It's really hard, and they need every support of the healthcare professional. And we need a very well described and trialed intervention that works specifically for women with PCOS, and that's what we're trying to come up with. At present, in the lack of any clear evidence, I tell my patients, if you're maintaining weight, you're not hoping to lose weight, follow a Mediterranean diet, a DASH diet, or a low glycemic diet, basically anything that has very little sugar in it, and that will maintain weight. If you want to lose weight, you need something a bit more aggressive. And examples of these, although there is not much evidence behind them, is intermittent fasting, shake diet, or liquid diet, and keto diet. These are all sort of evidence is emerging, and we're trying to do more research on them. But you're more likely to experience rapid weight loss, and we know that those who lose weight rapidly, they restore their ovulation, they restore their periods, they enjoy a spur of normality coming up immediately after this weight loss. Again, semaglutide, I get a lot. Every nurse in my practice currently is taking semaglutide in private. It's becoming sort of a front runner in terms of losing weight. It's promising. Big caution: you cannot get pregnant if you're on it, so you need reliable contraceptive if you've taken it in private. Very, very, very hard to give it in the NHS, and there's just no funding on it. So most of the prescription we write is private prescriptions, and I think we need more evidence. Most trials now are translated from diabetic populations or elderly population. They're not the same as women with PCOS who are younger, and they have different profile. And the key thing is that you lose the weight, but then you gain it back very quickly once you're off it. So you need to use the semaglutide with a lifestyle intervention, not on its own. And that's where, this holistic support is really required for women with PCOS.
I think just finally, one thing to say is that sadly, these interventions are not funded well enough by the NHS or by the taxpayer. To get onto a tier 3, which is a fairly intensive intervention in my community, there's probably about a year's waiting list. So again, lobby for the NHS to get more resources so that we can actually get rid of some of these waiting lists.
You're on mute, Rachel. You're on mute.
Sorry, I did that while I was typing the poll question. So is it possible to see a dietitian on the NHS if you don't have diabetes as a preventative measure? How easy is that to happen, Judith?
So every practice should have a dietitian allied to it. At my practice, you can just book directly with a dietitian. You don't have to go through the GP.
Yeah. Right. Conscious we've only got about 6 minutes left to go. So I think we've covered weight as well as we can. We've got quite a few questions around acne and hair loss and excess hair. We can spend a few minutes talking about those because they're often overlooked in regards to some of the other subjects. So some of the questions are around what would you suggest for a patient who can't take the combined pill for acne? What are the options for treating acne? Who do they go to? Is it the GP? Do they need a dermatology referral? How do they get that?
So all of the treatments on the slide from DNet and above can be prescribed by the GP. So, again, it's important the GP sees, assesses, has a look at the cause of acne, investigates it if necessary, etc. If somebody doesn't have a diagnosis of PCOS. And if, for example, I think there was somebody in the chat whose BMI precluded them having the combined oral contraceptive pill, and they also had severe acne, then for me that would be a referral to the dermatologist for consideration of other treatments. Now, to manage expectations, the dermatologists don't have any magic treatments really, apart from Roaccutane. So Roaccutane is a very effective treatment for very severe cystic acne, but it also has some pretty nasty side effects as well. And that's why it's prescribed only in secondary care, and you need to have blood tests to monitor your liver and have an assessment of mood, etc., because it can be a depressant as well. And but having said that, it is very effective. People seem to be able to take it for sort of 6 to 9 months for severe cystic acne, and then can stop it and maintain the benefit of that for quite a long period of time afterwards.
Right.
Anything else you'd like to add, Bassel?
No, I think spot on. Have very little to add to this.
Yeah.
There is one question on the subject. Is this person has been on the pill because of the irregular periods, but the acne didn't clear up, which is affecting her mood. But they're concerned, obviously, about coming off the pill and then increasing their risk of endometrial cancer because of not having periods. So they feel in between a rock and a hard place. What would the advice be for that?
So I'm just thinking, so they've got acne, they've got, they're not having regular periods.
They're on the pill to treat the acne, but the acne is not clearing up with the pill.
And they're also went on the pill because of too few periods?
Yes, and are nervous about coming off the pill because of the too few periods coming up, but it's affecting their mood.
Yeah.
So,
go on.
Well, I was going to say, I think again it depends on individual context. We're bound to say this again, but if weight is an issue, losing weight will obviously, if that's possible, will perhaps bring the periods back and improve the acne as well. I think I'm a bit lost from now on. I think I probably would be thinking about dermatology in terms of the acne, and I can't quite think of alternatives in terms of the periods, except perhaps to think about a Mirena coil, where you've got a much lower dose of progesterone, which is much less likely to exacerbate the acne than anything else. What would you say, Bassel?
No, I agree. I think it's often thought that you can primarily manage the acne with the pill, but it's not always the case. I sometimes put patients on the normal pill and then combine it with spironolactone or duostride, and they're actually quite helpful in some cases. We're just publishing an article showing that spironolactone can be quite effective in terms of, and there's been a recent article in the BMJ on this. So combining it with the pill is not a bad option. I know it's polypharmacy, and then we're asking the patient to take too many pills, but it's an individualized care, and it's just a Mirena, like Judith mentioned, combined with duostride or spiro could be quite effective in these cases.
And can you just mention the monitoring with spironolactone? I mean, I'm more familiar with using it for hypertension, and we have to really watch kidneys very carefully with it. Do you do the same in secondary care?
We do initial 6-month liver kidney function, and then sometimes it's repeated. And if the dose is stable and they've been completely fine on it, you don't need more frequent monitoring.
Yeah.
Great. Just a couple of minutes left. We have a question here around what is the best treatment for excess facial hair for black and brown women. They've tried a fluorescein cream, laser, and electrolysis. We've had a similar question come separately, which was around treatment options for excess hair besides Vanica, which wasn't accessible.
So I'll hand this one to you, Bassel, I think.
Yeah, again, look, I'm not the dermatologist in the call, but in such resistant cases, I think, again, taking this holistic approach, that you can add metformin that can sometimes help, in addition to spironolactone, to help with the excessive hair. Weight and BMI loss, again, has been shown to help with that. Often you might need to go onto a session of laser, which I know that it's not available on the NHS, unfortunately, and then continue on a maintenance dose of spiro plus metformin. So the treatment will need to be a bit more sort of bespoke and individualized in these cases. And in my practice, I certainly involve a dermatologist with interest in PCOS and acne, because again, not all dermatologists are equal in that field.
I think we're unfortunately at time now at 1:30, and I'm conscious everyone's got you have busy clinics and work to get back to. So I'd like to thank you so much for giving up your time today to go through this important discussion. And as is typical, there is just no way that we can get through to every question and area. So apologies if we have not answered your question. We will commit to doing these more regularly. And I think what's come through very clearly here is that we will look to do a specific session for dermatology. and we work with a fantastic PCOS specialist dermatologist that we will invite on. So if you're not already following Verity on your social channel, like on our social channels, please do, because we have some great webinars coming up, and I will prioritize a dermatology one ASAP. Perhaps we can do another GP and specialist one, and I think we haven't touched on fertility, which is rare, that haven't come up. So thank you so much. We will share the recording of this on our social channels and the slides that Judith has very kindly and graciously put together, which has amazing information throughout that you'll be able to draw on afterwards. So any final words, I think, from either of you to wrap up today?
I just want to say thank you. You do great effort, and Verity is a fantastic, all volunteer based in an organization that is doing all this amazing work. So I'm very grateful, and on behalf of patients. And as we started this webinar, I think knowledge is power. So please take initiative of your health and seek the right information. And you might not always find the right healthcare professional to listen to you. But if you are informed, you will achieve your objective and hopefully enjoy a very healthy life.
Thank you.
I haven't got anything else to say. That was lovely, Bassel. So we'll just reiterate everything you've said, and really, really good. Thank you all for coming along today, and it's really good to be able to interact with you. And thanks again to Verity.
Great. Thank you all so much. And we shall do this again soon. Bye-bye.
Bye.
Bye-bye.